Approach to shock. My name's Gary Harris, and we're going to discuss shock. Here's an overview. We'll discuss the definition, the pathophysiology, the clinical features, the physical examination, the pharmacology, the relevant investigation, the transport decision making, and the leadership roles. There's multiple definitions of shock. A life-threatening generalized form of acute circulatory failure associated with inadequate oxygen utilization by the cells. A severe mismatch between the supply and demand of oxygen is a common feature of all types of shock. Inadequate perfusion of the body's tissues, resulting in adequate supply of oxygen and nutrients to the body's cell tissues. Shock is a whole body response to an inadequate supply of oxygen within cells, tissues, and organs from one or multiple causes. Classified in 4 stages. Initial, early shock. Compensatory, decompensatory, progressive shock, and refractory, irreversible shock. The initial stage. Demand for oxygen to the cells falls below the levels required to maintain normal aerobic cellular function. When oxygen content or pH of blood drops sharply or carbon dioxide rise, chemoreceptors in the aortic arch and the carotid body reflex activates the sympathetic nervous system. Hypoxia develops, lactate levels rise, and cells cannot maintain homeostasis. The body attempts to compensate to return perfusion to homeostasis. As a result of the chemoreceptors being stimulated by the demand of oxygen, the medulla oblongata stimulates the adrenal medulla to release catecholamines, epinephrine, and norepinephrine in an attempt to increase venous tone, increasing heart rate, and myocardial contractility, and constricts blood vessels, increasing both preload and afterload, subsequently to increase cardiac output. The diagram reflects the location of these nerve fibers and the sensory actions of these baroreceptors. The compensatory stage neural response is that the heart rate goes up. There's increased contractility, arterial and venous vasoconstriction, and shunting of blood to vital organs. Hormonal response to compensate is to activate renin to stimulate the release of angiotensin 1, which converts into angiotensin 2 to cause vasoconstriction. Aldosterone, an antidiuretic hormone, is released promoting sodium and water retention to increase preload and cardiac output. Sympathetic nervous system controls are activated. But note, please, that patients on beta blockers are unable to launch a compensatory tachycardia. Demand of oxygen to tissues is already severely reduced, and patients tachycardic in an attempt to take more oxygen while exhaling excess carbon dioxide. The pH has created an acidotic condition as it's lowered and reduces the ability of the hemoglobin in the red blood cells to bind with and carry oxygen, further compounding the oxygen deprivation. This diagram illustrates what I've been discussing. It shows the physiology of shock, where that sympathetic activation has stimulated the sympathetic nerves and adrenal medulla. There's a release of that norepinephrine and epinephrine into the sympathetic synapses in the bloodstream. And there's a systematic arteriolar and venous vasoconstriction in an effort to increase myocardial contraction and heart rate. In a homeostatic sense, it is to increase cardiac output and blood pressure. The endocrine response is to decrease the arterial pressure and stimulate the posterior pituitary to secrete an antidiuretic hormone. This leads to vasoconstriction, leading to increased systemic vascular resistance, and blood pressure and venous return are increasing the preload and cardiac output. The renin-angiotensin activation stimulates angiotensin 1, which converts to angiotensin 2 by angiotensin converting the enzyme inhibitors. This causes arteriolar constriction and stimulates the adrenal cortex to release aldosterone. The kidney conserves sodium and water to increase preload and cardiac output. Decompensation stage of precursive shock. Shock will progress to an uncompensated state, failing to meet metabolic needs. Compensatory mechanisms fail to supply much needed oxygen to the cells. Hypertension becomes more prominent, and hydrostatic pressures increase, causing edema and third spacing. The body preserves blood flow to the heart and brain at the expense of the gastrointestinal tract, the skin, and the skeletal muscle. Microemboli develop, and increasing ischemia in the tissues and organs. There's impairment of glucose use, the fuel of the cell. Together, catecholamines and glucagon promote glycogenolysis and lipolysis. Cells shift to glycogenolysis and gluconeogenesis and lipolysis to generate fuel to survive the catecholamine output and the glucocorticoid production, creating a catabolic state. Plasma concentrations of glucagon rise. Excuse me. High serum levels of cortisol, thyroid hormone, and catecholamines account for the hypoglycemia and insulin resistance, tachycardia, and increased stroke volume, and increased cardiac contractility. The result, hypoglycemia, as well as elevated lactate and fatty acid levels, may be observed as the shock state progresses. Renin-angiotensin, aldosterone system activated in response to low arterial pressure. Cells without oxygen shift from aerobic to anaerobic metabolism, and adenosine triphosphate ATP stores are used faster than they can be replaced. Without adequate ATP, the cells start to lose their ability to maintain an electrochemical gradient across a selectively permeable membrane. The kidneys require high blood flow to maintain cellular metabolism. The adrenocorticotropic hormone is released from the adrenal cortex, increasing renal sodium and water retention, as well as potassium excretion, which support the intravascular volume. Simultaneously, the posterior pituitary releases additional antidiuretic hormone or vasopressin, which promotes reabsorption of solute-free water in the distal tubules and the kidneys. The sodium-potassium pump fails. Sodium is retained in the cell as potassium exits. This water is drawn into the cell as a result from the interstitium, further reducing the circulating volume. The cells become edemic, releasing lysosomal enzymes that cause cell injury and leakage into the interstitium. Lysosomal enzyme release further injures other cells, impairing metabolism and increasing cellular injury. The resting potential of the cells are reduced. Enzymes start to dissociate in acidic conditions, which impairs and eventually stops cell function. Protein depletion occurs as the body starts to use protein as a fuel for cellular metabolism. Consequently, they are no longer available to maintain cellular structure, function, and repair and replication. Final outcome of impaired cellular metabolism is a buildup of metabolic end products in the cell and interstitial spaces. Waste products are toxic to cells and further disrupt cellular function and membrane integrity. Heart responses include unmanageable hypertension, bradycardic arrhythmias, ventricular tachycardia, and ventricular fibrillation. This diagram illustrates for us how shock, as a result of impaired tissue perfusion, develops tissue hypoxia, becomes anaerobic in its cellular metabolism with an increasing amount of acidosis, causing cellular dysfunction. There's circulatory redistribution, ischemia, as the body attempts to reperfuse itself, further leading to cellular dysfunction, bringing us to a systemic inflammatory response syndrome and multiple organ dysfunction syndrome. This diagram illustrates for us the imbalance of shock when O2 supply and demand are interfered with. It's illustrated as the 4 types of shock: hypovolemic, cardiogenic, obstructive, and distributive shock. Synoptic view of the 4 types of shock are in the inner white field, with the organ systems primarily associated with them, the outer corners. Sites and mechanism of the manifestation, outside the circle, and pathogenetic and pathophysiological features, the outer and middle sectors of the circle. Shock pathophysiology. Cardiogenic shock is a failure of the pump to effectively pump blood. Intrinsic causes include left ventricular failure as a result of a large myocardial infarction, or right ventricular failure, or valve disorders, or cardiomyopathies, or septal defects, or papillary muscle ruptures, or sustained arrhythmias. So this failure of the pump to pump effectively has intrinsic causes as well, which include pericardial tamponade, effusion, pulmonary edema, and a tension pneumothorax. Hypovolemic shock is a loss of circulating stroke volume and cardiac output, both reduced. Conditions associated with it include trauma, acute aortic aneurysm, ruptured spleen, severe vomiting and diarrhea, hemorrhage, loss of whole blood, gastrointestinal bleeds, burns, excessive third spacing, and loss of intravascular integrity. Obstructive shock results from a condition that obstructs the forward blood flow. Causes include pulmonary embolism, tension pneumothorax, and pericardial tamponade. Distributive shock. It includes a number. Refractory, irreversible shock. Compensatory mechanisms have failed. Anaerobic metabolism progresses to permanent organ dysfunction as cells die. The treatment options failed to reverse mass effects. Multiple organ failure ensures. Multiple organ dysfunction syndrome. Organs affected early include the brain, kidneys, liver, adrenal glands, and heart. The basic features of shock are a collapse, cool, diaphoretic, and pale in appearance, tachypneic, suffering from confusion, agitation, anxiety, anxiousness, restlessness, altered level of consciousness, rapid weak pulse, delayed capillary refill, vomiting, dizziness, muscle weakness, and thirst. The clinical features of cardiogenic shock is an AMI, acute myocardial infarction, chest pain, or discomfort described as burning, pressure, or tightness. Diaphoresis, cold, mottled, or cyanotic peripheries. Altered levels of consciousness. Tachycardia or occasional bradycardia. Hypotension with systolic blood pressure of less than 90 millimeters of mercury. Respiratory distress, secondary to cardiogenic and pulmonary edema. Tachypnea, hypoxia, saturations of oxygen of less than 95%, and a wheeze. Hypovolemic shock, our central vascular system, pale, cool peripheries, with or without being clammy. Tachycardia and bradycardia, decreased pulses peripherally, capillary refill, less than 3 seconds. And systolic blood pressure, less than 100 millimeters of mercury. Our neurological status, we suffer altered levels of consciousness initially quiet with decreased alertness, confusion and agitation, and obtundation, mental blunting. Clinical features of distributive shock include septic anaphylactic neurogenic. So septic shock, blood pressure, less than 90, or a mean arterial pressure of 65 millimeters of mercury, oxygen saturations of less than 90%, and the person will complain of not passing urine for more than 8 hours. There could be prolonged bleeding from a minor injury or from the gums. Anaphylactoid. Anaphylactic shock, hypertensive, dizziness, bradycardia or tachycardia or collapse, difficulty breathing, wheeze, upper airway swelling and rhinitis, nausea and vomiting, diarrhea, abdo pain, and skin responses, urticaria, angioedema, and pruritus and flush. Neurogenic, suffers hypertension, bradycardia, thermoregulation failure, and in a spinal situation, a priapism. Obstructive shock can be caused by cardiac tamponade. Air accumulates in the pericardial space. Distended neck veins occur. And there are muffled heart sounds and pulses, paradoxus. Tension pneumothorax, air entry into the pleural space. There's diminished chest sounds on the affected side and jugular vein distension and a late stages tracheal deviation and hypertension. Now, pulmonary embolism can cause obstructive shock, presenting with cyanosis, hypotension, and right heart failure. So in our physical examination, our first priority is always DRABCDE, danger response, airway, breathing, circulation, defibrillation, and expose. Signs can be subtle or profound, so rapid recognition is paramount. Once the resuscitative measures are in place, a more detailed assessment begins, allowing you to reevaluate your initial assessment. Evaluate the vital signs, your perfusion status assessment, your respiratory status assessment, and your Glasgow Coma score. Complete your standard cares. Assess your colour, pulse rate and rhythm, your blood pressure, your respiratory rate and effort. Auscultate and look what the pupils are responding. Take your blood glucose level and evaluate, and also your pulse oximetry and temperature. Consider the patient's history. What's their chief complaint? What are their signs and symptoms, their allergies, medication, past history, last meal, events leading up to the chief complaint? Beta blockers and calcium channel blockers can alter the response to shock. With your physical exam, your vital signs can appear normal in the compensatory shock. Look for signs of poor perfusion and pulse pressure. Look for jugular vein distension or flattening. Complete your respiratory status survey. Verify your breath sounds bilaterally by auscultating the chest. Assess adequately the rate and depth of respirations. Monitor your oxygen saturation, and your perfusion status assessment will determine the need for oxygen therapy. Assess the ventilatory status with capnography. Expose the chest and inspect the anterior, lateral, and posterior for abnormalities. This brings us to our pharmacology, our adrenaline, the indications: anaphylaxis or severe allergic reaction, bradycardia with poor perfusion, unresponsive to atropine or transcutaneous pacing, shock, unresponsive to adequate fluid resuscitation, excluding hemorrhage, obstructive, or anaphylactic. A presentation is in an ampule of 1 milligram of adrenaline in 1 ml, 1 in 1,000 adrenaline, or 1 milligram in 10 mils, 1 in 10,000 adrenaline. The indications are anaphylaxis or severe allergic reaction, bradycardia with poor perfusion, and shock unresponsive to adequate fluid resuscitation. Remember, excluding hemorrhagic, obstructive, and anaphylactic shock. The adult dosage for anaphylaxis is 500 micrograms, repeated at 5-minute intervals with no maximum dose. The IV infusion is 6 micrograms per minute. For pediatric doses, QAS clinical consultation is required and approval required. The anaphylaxis is an IM injection for the over 6 years of age of 300 micrograms every 5 minutes with no maximum dose. Or for bradycardia with poor perfusion, unresponsive to atropine and or transcutaneous pacing. Again, QAS consultation is required and approval is required. Human fibrinogen. It presents in 2 vials, powder and a solvent. 1 gram of human fibrinogen dissolved in 50 ml of water for injection. The indications are suspected traumatic hemorrhage. The adult dosage is up to 50 kilograms, gets 1 gram, 50 to 75, 2 gram, and over 75, 3 gram. In critical bleeding situations, administer via a slow push over 2 to 4 minutes with a maximum dose of 3 grams. QAS clinical consultation and approval is required. Hydrocortisone. The indication: severe allergic reaction or anaphylaxis requiring adrenaline administration. The presentation is a vial of 100 milligrams of hydrocortisone. The adult dose is an IV of 200 milligrams. Slow push over 1 minute, and it's a single dose only. The pediatric dosage is an IV 4 milligrams per kilo, single dose not to exceed 100 milligrams. Norepinephrine. Indications: shock unresponsive to adequate fluid resuscitation, excluding hemorrhagic causes. The presentation can be variable, but the adult dosage: commence infusion at 5 micrograms per minute or 5 ml per hour and increase by 1 or 2 micrograms every 3 to 5 minutes as determined by mean arterial pressure. There is nil authority for QAS to administer in pediatrics. Ondansetron. The indications of nausea and vomiting prevalent in shock situations. The presentation is an ampule of 4 milligrams and 2 mils, or it comes in a tablet form in a wafer of 4 milligrams. The adult dosage is 4 to 8 milligrams IV with a maximum dose of 8 milligrams. The pediatric doses are 100 micrograms per kilo IV and a single dose not to exceed 4 milligrams. So extended life plasma. Its indications: ongoing hemodynamic instability secondary to hemorrhage following appropriate volume resuscitation strategies with our crystalloids. The presentation is in a 250 to 310 ml bag, group AB positive. The adult dosage is 1 unit, alternating with red blood cells if available. QAS consultation is required. Pediatric dosage is 10 mils per kilo up to 1 unit. Again, QAS consultation is required. And titrate according to the indication and patient physiological response to treatment, and administer via an approved blood warmer. Sodium chloride. Indications are inadequate tissue perfusion and shock. Hypovolemia. Presentation is in a Vivex plastic container of 100 mils and 500 mils. Adult dosage is PRN. Pediatric dosages are 10 to 20 mils per kilo with a total of 60 mils per kilo. Recent large, well-designed observational studies support the benefit of early initiation of appropriate antibiotics for patients with sepsis. Among the 4 largest studies, the odds that the patients with sepsis would die increased by 4 to 12% for each hour of delay in antibiotics. This relevant investigation recognised that advanced life support paramedics of patients with septic shock shorten their time to proactive intervention in emergency departments significantly. This was further found in further studies where the key components of the management of septic shock are early identification, early oxygenation, early hemodynamic resuscitation, and hospital notification. So our transport decision making. It's a dynamic risk assessment that should be part of every case. The concept of time-critical patient allows the recognition of a patient's condition or likelihood of deterioration. This identification directs the appropriate clinical management and ensures the appropriate destination to improve the patient outcome. Early notification of the receiving facility ensures preparation and early activation of appropriate patient treatment pathways to enhance patient outcome. Consider aeromedical support if you're more than 45 minutes from your major hospital. Your leadership role. You have a clinical leadership role on scene. You must demonstrate high levels of clinical knowledge to underpin practical development of critical care in and out of hospital phase of patient care. You have to apply sound clinical reasoning and analytical and problem-solving skills to assess patient needs and review patient health care to determine best care alternatives. You need well-developed interpersonal and communication skills and a proven ability to negotiate, consult, and collaborate with a diverse range of stakeholders. You are required to demonstrate planning, critical thinking, and organisational skills to effectively manage time through prioritising, delegating, and the ability to ensure workplace health and safety standards are maintained as the lead clinician managing incidents. You must have the ability to remain calm and maintain performance under pressure without negative impact on self or others. Furthermore, you have the ability to work with and lead other staff and maintain positive and productive relationships with others. We've covered the approach to shock. We've discussed the pathophysiology, the clinical features, the physical of the examination, the available pharmacology, relevant current investigations, transport decision making, and the critical care paramedic leadership role. Thank you. Types: neurogenic shock, loss of sympathetic tone caused by trauma or drugs, anaphylactic, anaphylactoid shock, addisonal crisis, a myoxemia edema crisis, a thyrotoxosis, or septic shock. The progressive disease typically resulted from infection and a systemic inflammatory response syndrome.